looks like we have one question right now. Is there any correlation between treatment-resistant depression, anxiety, and CTE? Could the depression and anxiety experienced by patients with CTE be different than major depressive disorder and maybe need different treatments other than SSRIs and CBT?
This is a really important point. People have heard a lot about CTE being associated with depression, anxiety, suicidality. And right now, we're not really sure that these types of syndromal kind of psychiatric disorders are indeed caused by CTE. These are complex disorders, depression, anxiety, with lots of different types of symptoms and signs for each. The question of whether they can be treated is a really important one. They can. Many of the symptoms and signs of these kind of psychiatric disorders in people who may have had a lot of blows to the head can still be treated. And they may be treatment resistant, something like many other individuals, and appropriate, sometimes trial and error of different medications to get to potential reduction of symptoms. And I think people should have hope for that. With that said, you have to look at the specific symptoms. And there may be parts of depression or anxiety that might mimic some of the specific problems and clinical features we see in people with CTE, part of that neurobehavioral dysregulation. And those things may be harder to treat, perhaps, in the traditional way. I think there's still going to be hope for those types of symptoms.
I think I just emphasized that we try not to focus as much on the cause because we don't know if they're related to CTE or not, or if CTE is present, but rather we focus on the treatments we do know that work with depression and anxiety. And anecdotally in our clinic, we find that the treatments for depression do work. They get involved in talk therapy and psychiatry, and they get benefits. So I think that's important.
So our next question is about Dr. Ann McKee's talk. She showed some interesting findings in a sample of 143 brains from ages below 30 with 60 with CTE. Is this typical for the young group? And are we closer to estimating the population prevalence of CTE in the young and older groups?
So I might be able to address this because I'm working closely with Dr. McKee on the study. I think what she's finding is not typical for that age group, finding lesions of tau. Granted, the overall pathology observed, especially the tau, isn't extensive, but it's something that likely shouldn't be there for that age group. But importantly, there needs to be a control group. So what the problem here is that young brain donor controls are very hard to come by. That would be really important for really identifying are these abnormalities. But it's really important finding that where she's even seeing kind of gross changes to the brain in this young age range.
It seems the focus has been on NFL players. What about college players, which is a bigger pool?
This is an important problem for everybody who is in contact sports and is worried about their risk, and for their parents of those individuals, including children who participate in sports. In the Alzheimer's space, we've typically started with people who are looking at biomarker changes, for instance, in persons with Alzheimer's dementia, and then worked our way back to see whether you could detect these more subtle changes despite more limitations in statistical power in milder stages of the illness. And we've been interested in detecting and tracking those changes decades before the onset of symptoms in people at genetic risk, for instance. I think we've started in the same way here. This is intrinsically important topic. All the wonderful work you've seen spearheaded at Boston University and NFL players is important for that group itself, but really a foundation for understanding these changes and studying them in individuals with a range of repetitive head impacts, including a number of contact sports, including individuals who've been exposed to repetitive abuse over years and others as well. We have a lot more to do in that space, but I think starting in the NFL players and expanding has been, to me, a sensible strategy.
We had to start with people who seem to be at the greatest risk to examine potential biomarkers. College football is much, much more common. We're talking about millions of former players in this country, but it's not even just former college players. We're talking about former high school players. So we need to really look at a much more global assessment of people with repetitive head impact exposure. Within football, that means across the different levels of play. But what about, like we spoke about earlier, soccer or the real football, the beautiful sport, that there is now growing evidence that heading the ball in soccer and other repetitive blows seems to lead to later life problems with huge mortality risk for neurodegenerative diseases in professional players. But what about all those other people who are not being studied? And so we need to go beyond football. We need to go even beyond soccer. We need to study women. We need to study individuals, especially with an extensive history of intimate partner violence or domestic violence. There are so many people out there with the potential for adequate exposure to start this neurodegenerative process. So we're still at the beginning of this entire research endeavor. I know Dr. Alosco is doing some fabulous work with all types of individuals with repetitive head impact exposure from different sports.
Yeah, right. That's kind of one of the studies I referred to in my talk, where we're really trying to cover all sports, hoping to get a better sense of risk in the other sports.
The attendee asked whether PET tracers of neuroinflammation, including those for microglial activation or reactive astrocytosis, have been tested in CTE patients. Although not specific to CTE, increased uptake in related brain regions may be an early event preceding tauopathy.
There's clearly great interest in the understanding of microglial and inflammatory changes in a range of neurodegenerative diseases. And we've all had a strong interest in finding PET methods in emerging CSF and blood-based biomarker methods to do that. While there have been some promising PET measures for this, they're not quite as good in general as some of the other measurements we have. Over time, it's harder to learn from them. We still think there is an important opportunity to do that, given the limited amount of data and ability to have a sense of exactly what we're measuring. It wasn't prioritized, for instance, in diagnosing CTE the way tau PET and amyloid PET would be, but still very important.
Dr. Coughlin at John Hopkins has looked at TSPO tracer in former NFL players. It shows some interesting signal in that group. Beyond those studies, I'm not aware of other tracers of neuroinflammation that have been used here, but I agree with everything Dr. Reiman said, and I think it's really important.
You know, some of these potential biomarkers are for research purposes. Some are going to hopefully be for diagnostic purposes, hopefully some for early detection. And so we have to understand that there isn't going to be this wonderful, perfect single biomarker that's going to be both sensitive and specific to CTE in the next few years, just like there hasn't been one for Alzheimer's disease, but we're getting much better. Other PET tracers, they're going to be really helpful for our research purposes, our understanding of what's going on, maybe the ability to develop new medications for clinical trials. My own personal belief, we're going to get to the point of having blood biomarkers. With the incredible advances that have been taking place, we're going to probably have pretty specific blood-based biomarkers for CTE tau that will be able to be used even early on for detection. It's not tomorrow. That's where the field is going.
Which would be extremely important, having affordable, widely scalable, rapidly repeatable measurements like that would really be very important. In the inflammation space, we are seeing encouraging things with regard to CSF and plasma measurements of a few inflammatory biomarkers. The one that has gotten the most traction right now is called GFAP, an indicator of astrogliosis, a kind of inflammation that we can detect and track relatively early, for instance, in persons with Alzheimer's disease and certain other related disorders.
Would tau PET be a useful evaluation for detecting CTE in a 15-year-old female soccer player? Or what other strategy would be recommended to the parents of this girl who manifests repeated anger, occasional extreme violence, slapping her mother, poor grades, and has conduct disorder diagnosis? She tests I'm not sure if she's impaired on measures of executive function from the comment, and is thought to have ADHD.
Yeah, boy, my heart goes out to those parents, number one. And it's not an uncommon type of question. Unfortunately, some of the misunderstandings out there about CTE and about what might cause it and detection of it have led so many young people and their parents to think that they've had a concussion, from youth or high school sport, and therefore they may be at risk for having this neurodegenerative disease. Or if they're showing problems of any type during younger ages, and they happen to play a sport and may have had several blows, including some symptomatic concussions, that it's due to CTE. And I think what people have to understand is that we would not expect there to be enough progression of CTE neuropathology in a young person at age 15 to result in symptoms. It just doesn't work in terms of the overall mechanism and pathogenesis of the disease. Even though we can detect it, especially the very early stages, in people in their 20s, maybe even late teens, but that doesn't mean that they would have a huge constellation of very difficult behaviors and cognitive impairment. Rather than think about CTE, I think the important thing is to realize there are lots and lots of other important causes of adolescent, especially in this case, adolescent behavior and conduct and cognitive difficulties, including ADHD, including symptomatic concussions. And if this young woman had some pretty important symptomatic concussions, there may be some residua features, but there has to be the focus on what can be done in terms of evaluation and treatment that's appropriate for age, and not necessarily jump to thinking, aha, this is CTE, let's do a PET scan for it.
Indeed, if I can just suggest, first of all, my heart goes out to the family as well. For parents, you're only as happy as your least happy child. And again, my heart goes out for that challenge. But even in older individuals, when we talk about using, whether it's an expensive or inexpensive diagnostic technique, we'd like to have confidence that we can learn something about a positive or negative finding in terms of relationship to the pathological standard of truth, or we'd like to have information that could inform a person's clinical course, or we'd like to have information that could inform planning and management. We don't have that yet. And I would not be recommending TauPAD to support the diagnosis of CTE just yet, for all the reasons we've discussed so far today.
Our next question is about how sensitive are the neuropsychology evaluations, standard neuropsychology evaluations, to pick up on the cognitive decline associated with probable CTE. This attendee says, I've treated many retired football players who have played 15 or more years in the NFL, have neurobehavioral dysregulation, and report cognitive issues like short-term memory loss, but neuropsychological evaluations do not show these deficits. Could this be different from how we use the neuropsychological evaluations for major neurocognitive disorders like dementia?
This one is close to my heart because it's something I think about constantly, and I encounter very similar experiences. And our data also is similar too, that we just have a paper under review from Diagnose CT looking at the neuropsychological patterns in that group. I think it's very common for people to present to the clinic with overwhelming concerns, corroborated by their informant. Their life is in disarray, and yet they have relatively normal testing, neuropsychological testing, or it's mild, kind of patchy impairments. I think it's a combination of several different factors. I think one, it's a function of our tests. I don't think we have great tests to catch the types of impairments that we might be seeing in this population. Two, I think a lot of these individuals present to us when they are young. As a result, how far along the neurodegeneration is to result in objective evidence of impairments might not yet be there. And then the other component is that maybe it is a lot of this neurobehavioral dysregulation that manifests as thinking and memory problems during life. But when you sit them down in this artificial quiet room, they're able to test out okay on the testing. It becomes very difficult to explain this to the patient who's experiencing it and what it means and what's the discrepancy about. I think that is an issue. I think we really need to focus our efforts on test development there to capture the impairments we're seeing.
Our next question is about the differences between the clinical description of concussion and subconcussion. Would you suggest that these two impact the different exposure types may cause primary mechanical damage to different tissue types in the brain? Could this damage be happening by different damage mechanisms? Would this influence the pathology or rate of CTE development if repetitive exposure occurs, for example, in soccer?
There's a lot there, and I'll try to unpack. Let's start with concussion and subconcussion. Concussion right now, by definition, is when you hit your head and there's symptoms, and it's defined by having those symptoms. And the question is, what happens when the person doesn't complain? What happens if there's no assessment? What happens if the specific injury does not lead to some kind of observed or reported symptom or sign or symptom? We might consider that a subconcussive injury. By definition, it doesn't reach the level of injury that would result in the symptoms, the clinical features of concussion. That's the main difference between them. The issue is that there's a whole lot more of those subconcussive blows than there are symptomatic concussions, because those subconcussive blows just keep on happening. That doesn't make someone have any pain. It doesn't make someone have symptoms, so they keep on getting hit regardless of what the source of that exposure is. What seems to be happening is that when the injury occurs, whether it's concussive with symptoms or subconcussive, there is an inflammatory response. It's a helpful thing. We need that to be able to clear out some of the bad stuff, lead to recovery and improvement. But if there aren't any symptoms and the person's continuing to get hit, or even if there were symptoms and the person continues to get hit, there's an increased inflammatory response as well. The neuroimmune system comes to the rescue, and there can be this additive inflammation that might then lead to the worsening of the original problematic neuropathogenesis. If you keep getting hit, there's increased kind of neuroimmune response, inflammation, and worsening. That seems to be what's happening at the early stages of this disease with the initial accumulation of tau. Someone has a concussion, maybe they stop getting hit for a while. They get recovered. They don't have this additive inflammation. So that's a big thing. And I think people have to understand that so far the data suggests that a single concussion or a few concussions does not lead to CTE, unless there's also additional repetitive head impact exposure and those subconcussive blows. With that said, recent findings led by Jesse Mez was that it's not just the overall cumulative exposure, it's also the intensity of that overall cumulative exposure. Using our development of these exposure science models, it seems that it's not just the number of hits, it's the number of more intense hits. We don't know where that line is. We don't know what the threshold is. We don't know what the specific types and sources of the hits are. That's why we need to do so much more research to figure that out.
We have a question about whether there's any data as to the minutes of play, the number of games, and what string the player was on, bench versus starter, offense, defense, if they had tackled, etc., and developmental history regarding childhood abuse.
We try to capture as much data as possible to best estimate cumulative exposure to repetitive head impacts. I think we capture some of those data points you mentioned, and like Dr. Stern just mentioned, Dr. Mez has created an index that incorporates some of these granular data points. And we're also starting to assess kind of earlier in life factors as well, such as childhood abuse, but we haven't not yet looked at that data.
Are there strategies considered to address the differential effects of social determinants of health or substance abuse on imaging findings, Are these variables included in regression models to account for potential confounders?
It's a very important consideration. The area that we have focused on the most right now is the impact of race, which distinguishes a couple of our groups, including the NFL player group. We've been able to do some analyses to suggest that the changes we're seeing aren't solely attributable to race, but very important. And social determinants of health is an important variable for all of the work we do in this area and in other areas of medicine as well. More to do. Again, I want to remind folks there is going to be an opportunity to have access to this invaluable data set to think about ways in which to approach the issues, and that is a good example.
And when we started the Diagnosing CTE research project, we knew that this was an issue, but it was designed 7 or 8 years ago. I have to acknowledge myself that I knew things would be important, but I had blinders on about how important social determinants of health and racial disparities and ethnic disparities would be in looking at this type of incredibly complex disorder, from the neuroimaging findings to the cognitive findings. Who decides to play football? For what reasons? Who has perhaps lower thresholds for initial vascular disease based on nutrition factors and stress factors and other psychosocial factors that are perhaps at the root of some of the race differences that have been found. Fortunately, things have changed since our early days when we designed the Diagnosing CTE research project. We've added some additional measures in our follow-up assessments, and in other studies that we're conducting, we're looking in greater detail at some early childhood stressors and experiences and trauma. We're trying to look at it. We have now several people on board in our group working specifically on these issues. But like Eric said, for the diagnosis data, it's going to be available for people to look at. But this is one of the most important things we need to look at. It's not just you get hit, you get CT, you get symptoms. It's a very complex, incredibly kind of synergistic risk environment.